Good afternoon, everyone, and you are very welcome to this episode of QPS TalkTime. Do please follow us on social media. You can watch back on previous QPS TalkTime episodes on the YouTube channel at National QPS, and you can follow us on LinkedIn at HSE National QPS. Just a reminder there of our podcast series, the Walk and Talk Improvement podcast series, a special episode that Juanita Guider and I did recently with John Berwick. He was very generous with his time, and I think you would really enjoy listening to this. He's got so much to say still, and I think is very relevant, and so check that one out. And we also have a new Walk and Talk Improvement podcast with Keith McCandless. Now, people would be familiar with Keith McCandless from Liberating Structures. And again, I think check out Keith and Juanita in conversation. And also that might be a good way to learn about liberating structures if people are interested in that. So in today's webinar, we're going to hear about AI in healthcare in Ireland, legislation, strategy, policies and guidance. We're going to share stories of how AI has been used to support staff with clinical audit and registries. I'm going to signpost you to some resources on Clinical Audit Awareness Week, which is coming up soon. So it's a pleasure to welcome our speakers today. I'd like to first of all welcome Dr. Orla Healy, National Clinical Lead for the NQPS. You're very welcome to QPS TalkTime, Orla.
Thank you, John.
And Majella Daly, Assistant National Director, National Centre for Clinical Audit. Majella, you're welcome.
Thank you, John.
And then we have two guest speakers. I'd like to welcome Professor James Teo, Professor of Neurology at King's College Hospital in London, and Joint Director for Data Science and AI at King's College Hospital and Guy's and St Thomas's Hospital in London. James, you're very welcome today. And then Kevin Kelly. Kevin is the Head of AI and Automation at the Centre of Excellence in the HSE. So Kevin, you're also welcome to QPS TalkTime.
Thank you.
And we're all going to come together at the end for a panel discussion. And but first off, I'm going to hand over to Orla, and Orla, you're going to get us started on today's webinar.
Thank you very much, John. Delighted to be here. Good afternoon and welcome to everybody. Thank you for joining us for our Clinical Audit Awareness Week special. I'm here with our colleagues from the NCCA team and, of course, our guests. Thank you all for joining. This Clinical Audit Awareness Week 2025 is, as ever, an opportunity to promote clinical audit and quality improvement throughout healthcare. This year's events take place from after the bank holiday weekend onwards, so that's Monday the 2nd of June to Friday the 6th. Over the course of that week, you can learn more about clinical audit. You can find out about our latest resources and training to help you undertake an audit yourself and with your colleagues in your service. And you can hear more about clinical audits that are already happening. Thank you, Chris, for sharing a link where you can find out about more about audit. It's in the chat box. And with that, I would say that it's my pleasure to introduce the talk time, which brings us a timely and thought-provoking discussion on clinical audit and AI, humans and AI smarter together. That's the theme of this year's Clinical Audit Awareness Week. And this webinar is a unique opportunity to hear insights from a panel of experts that are leading in the field in Irish and UK healthcare systems. So over to you and thank you very much.
Thanks, Orla. That's great. And I'm going to hand over now to Kevin.
Thanks, John. Good afternoon, everybody. And thanks for inviting me to speak at this QPS talk time. So my name is Kevin Kelly. I've been working in the health service since 2004, and in the last 5 or 6 years, I've been heading up the Automation Centre of Excellence. So the Automation Centre of Excellence has now evolved to be the AI and Automation Centre of Excellence. We first launched the Automation Centre of Excellence back in 2020, just at during the first year of the pandemic. So the Centre of Excellence now is reporting into the Chief Data and Analytics Office. It's a new office that's been established within Technology and Transformation. and reporting into the new CDAO, Mr. Tom Laffin. So that's where we're situated. I mentioned that we've been doing automation since in and around the end of 2019. We piloted a number of processes, automated processes using a technology called RPA, or robotic process automation. So we would have stepped into the pandemic response quite quickly and began automating the transfer of live COVID cases into the CIDR system, the computerized infectious disease reporting system within the Health Protection Surveillance Centre. We're still involved in that effort, and we've extended that to now include other infectious diseases such as RSV and influenza. But over the course of the last 5 years, we've been busily automating other processes in other parts of the organization. Some of the low-hanging fruit, I guess, for RPA is in that area of HR and in finance, and we've been busy working with both of those functions, but also in the likes of the NMBI for validating the registration status of nurses and midwives, which is something we built last year and came into effect towards the end of 2024 and into early 2025. And then more recently, we've been automating the suspension and removal of patients from waiting lists in IPIMS based on data that the scheduled care teams in each hospital receives from the National Treatment Purchase Fund. So we're extending that piece of work with which commenced with Galway University Hospital into a number of hospitals around the country. I think we're now present in 20-25 hospitals, and that effort continues right through this year and maybe into next year. In terms of benefits that we saw with RPA, the sales brochure, really, I'm probably throwing it up there a little bit, but I'm picking out two on the right-hand side. And in terms of meeting demand surges, what RPA allowed us to do was very quickly scale up as the numbers of positive COVID-19 cases ramped up over the period 2020 to 2022. At its peak in 2022, we had 105 cloned robots processing upwards of 20,000 Omicron cases during the Omicron wave. We were able to, our HPSC were able to advise us that that was the number that they were expecting to peak at. So we were able to provision enough robots to deal with those numbers, and we hit those numbers for a couple of days during January or February in 2022. And now we've been able to scale right back down. We're in sort of peacetime, we're at about 20-25 robots, just processing whatever infectious diseases that are passing through. But again, very quickly able to scale up or scale back down as the case may be. In terms of clearing backlogs, one particular example was in the aftermath of the cyber attack, the criminal cyber attack in 2021, when all systems were off. So our robots were down, but also the systems that they would have needed to interact with. So we were able to clear, by the time we got back online, which was in around September, October, we had 4 months of data to clean up. And we were able to, again, scale up the number of bots that we had built to undertake that process. And we were able to clear that 4-month backlog in a fortnight. And again, very quickly, once we had those numbers done, we were able to scale back down. So it's almost been able to move a virtual workforce in, carry out a piece of work and move it back out. So, and RPA is sort of what I describe as the bottom rung of the AI ladder. Since then, we've been working with other intelligent automation solutions, most notably machine learning. We're doing that piece of work with the CCIO at the moment to extract large amounts of information from a large set of data. And this is all in an effort, it's a sort of foundational work to arrive at a point where there's a set of standardized referral forms. We've also been involved, or the HSE has been involved in a pilot around process mining. So that's a technology that plugs into a data set, and it's able to understand the degree of variance from a happy path in a particular process. So they ran a study, a piece of work against 3 years of data in a particular hospital. and we're able to understand the reasons for DNAs occurring or where DNAs hadn't been reported into the hospital, with a potential, if that was resolved, potential increase in capacity of 5 to 8% in that hospital alone, which is quite valuable information to have. But we're able to understand where the deviations occur and how frequently and the impact of those. That's what that process mining tool does. But I mean, AI isn't new. AI has been around for years, and the health service has been busily employing AI in many areas, including in clinical settings. Radiology is one prime area for AI, for the scanning of medical images and so on, and we've seen quite a spike in activity in that area and interest too. Many other clinical uses we've seen, and there's a lot of interest in the area of ambient listening or ambient scribing, and we've seen trials of that in Galway University Hospital and elsewhere. And also natural language processing is another type of a technology, an AI technology, where, and again in Galway, where they're using that to extract meaning from unstructured notes. So I suppose to bring up the speed on what's happening in terms of regulations, policies, and so on. 2 years ago, the Digital for Care strategy was published, and that sets out a vision and a roadmap for the use of digital technology in health and social care settings. So again, being aligned to that, we're now establishing an AI strategy and an accompanying implementation framework. But aligning that and the work we're doing currently with other productions or other publications that are on the way or are out. Case in point, I think it was 3 weeks ago, the government released their guidelines for the use of AI in the public sector. And HICWA are currently developing a set of guidelines around the ethical use of AI in healthcare. In the case of the latter, there's a number of us on that working group that are working towards that draft document and working on that draft. And similarly, HICWA have been involved in a working group that has been developing the HSE's AI strategy, or which will be a joint publication between the Department of Health and the HSE. Many other contributors and participants in that working group, including clinicians, patients, industry, academia, data protection office, and also the Department of Health and HICWA themselves, as I mentioned. Moving on to the strategy itself, the intention was that we were going to have that ready for the halfway point in 2025. So that publication is just about ready, and we'll be handing that across to the department, and the minister intends to announce that strategy. I think the intention was that it would happen before the Dáil rises for the summer. So that piece of work is pretty much done. I've just taken one graphic from it, and again, it is still in draft. So if that changes, forgive me. But we're setting out a horizon roadmap for the use of AI in healthcare across 4 distinct pillars: AI for clinical, for operations, for research, and also for public health and the management of population health. And setting out ambition, I suppose, across year 1, year 2, 3, and then beyond, across the various technologies that are on the landscape. I also mentioned an accompanying implementation framework. So this is going to set out how we deliver that strategy, and I suppose we're not going to make any apologies for adopting a position of care. And considering the data that we're dealing with, considering the industry that we're involved in, but we want to do that without necessarily inhibiting or stymieing innovation and potentially missing out on opportunities that would deliver better care or more efficient care across the organisation. We also have to be very aware of our obligations under the EU AI Act, which was released midway through last year, and there's going to be a phased enforcement of that over the next year or two. But that sets out some very clear parameters for the use of AI and for all organizations and not just healthcare, but a particular emphasis on the care that we have to deliver as a health organization. So my final slide, I suppose, and we're, an overriding principle is that, this has to be human-led, and there has to be human oversight on any use of AI that we deliver, clinical or otherwise. Any AI solutions, and especially those in those clinical settings, must be trustworthy, transparent, ethical, and we're factoring all of that into the implementation roadmap and any of the governance structures that we're setting up, and taking a very clear voice or a clear steer from the patient. I mentioned the patient representation on our working group, and point people towards the IPOSI Citizens Jury Report, which was released earlier this year, which was very clear in its position and reflecting the patient's position, that the primary focus of healthcare should remain with the human, with AI being used as a support or a decision enabler. But so that's where we're at the moment. Quite a lot going on, a lot of interest in this space, but we're trying to take it, taking an approach of caution without necessarily inhibiting innovation, and I think that's the key point. So thank you for listening, and I'm happy to take questions later on.
Thanks, Kevin. That's fascinating. Yeah, there's so much going on there. I really wasn't aware of the volume of work, and obviously, the things underpinning all of this. And so that'll be great. We're going to, get you back for the panel discussion, and I'm sure there'll be some questions from the audience. I think our audience is certainly lit up by our provocative question, and I think we've got lots of good responses there. Kate Ferguson saying AI has a role in policy and compliance. Jared Crotty reminding us that if we don't incorporate AI with guidelines, staff will use it anyway. So I think, we have to be thinking about how we can do this safely, as you've been pointing out, Kevin. Stephen Gately saying, if we do not utilize AI to promote and enhance clinical audit, we risk falling behind. And Paula Kavanagh saying AI can transform how we see patterns and predictions for audit. And that brings us very nicely to our next talk. James, you're very welcome to QPS TalkTime. And I'm going to hand over to you. You're going to talk to us about language AI for analytics, audit, and research. And you're very welcome. Thank you.
So I'm a neurologist. I'm from slightly across the other side of the Straits. And I'd like to talk a little bit about the work that I've been doing. I have lots of hats, and I've been working in this space for nearly more than 15 years now. And back then it was a really, really boring thing for us nerds. But suddenly I'm discovering that I suddenly have a lot of people I need to talk to who want to talk to me. So it's a pleasure to come and talk to you. So as with these things, I have a number of declaration of interest because a lot of this work is infrastructure heavy. I involve a lot of technology companies and a lot of charities and life science companies to build the infrastructure for it. So just to declare that all in advance. And if any of the projects here relate to that, then I will mention them in the talk. So we're in the hype cycle. Okay, and those of you who are not familiar with the hype cycle, the hype cycle is a concept which where some sort of innovation triggers, and suddenly lots of people hear about it, and everybody gets super, super, super excited, and then you get this peak of inflated expectations where it's supposed to revolutionize everything. Then after we reach that peak, we discover, oh, it's a little bit underwhelming. It's a little bit overpromised. And then it kind of collapses into this disillusionment bit. But then we get to a stage where it becomes used. And I think we have to recognize this. This has happened many times, not just for AI, the cloud technologies, a variety of different things. And I think we have to be a little bit circumspect and more sophisticated when talking about AI to avoid it becoming us falling into the trap of overinflating and building things which aren't, which will not happen. So what I need to talk about is that is what we call a hierarchy of needs. So for good AI to work, you need lots of big data and a good big data structure. And for that to work, you need a good digital infrastructure and common standards. And if you don't have the bottom tiers, then the AI you build at the top is kind of narrow and not very useful, or has limited uses, or is inflexible. And so, despite this being an AI talk, I want to kind of emphasize actually the role of the bottom 2 bits, because the bottom 2 bits are more boring. They are boring because they're all happening in the back. They don't have interesting pictures of robots and things like that. But it is actually what determines whether AI works or not. And the AI that a lot of people talk about nowadays are often large language models. So ChatGPT-like things, which has been around for actually even before ChatGPT for a while in the open source community. But this is not all of AI, as you've seen in the previous talk, which gives a very, very broad idea of all the different aspects of AI. But in this case, I'm talking about language AI and LLMs. And there are areas which are stronger and areas which is very weak at. So the areas which is weak at is arithmetic, for example. It's very bad at arithmetic. And you actually, it's like using something really sophisticated to do simple math, and you discover it just kind of falls over. This talk is going to focus about AI for reading and understanding rather than for writing. So obviously there is all these other tools for chatbots and all for writing, for interacting, for ambient listening of consultations. But for the purposes of an audit, the consultation has already happened. What we're trying to do is measure the performance of reading and understanding is much more important in this context than in this particular scenario than necessarily writing. And to do this, we have to really understand the nature of health data. So the nature of health data, I think some of this is going to be quite obvious to some of the staff people here on the webinar, but this is how health data is generated. So health data is generated at its source, first initially a doctor talking to a patient, or an X-ray, or a scan image, or his pathology, and then it's interpreted by the middle level of people, these black silhouettes, who interprets and records it. And a lot of people record it into either forms or documents, and documents are often in free text because that's a very natural way for doctors to interact with information. They write things, they write narratives, they write stories, they record outcomes and things like that in language. And then it's a second step after this, in which the second layer at the bottom, analysts, audit managers, clinical coders, various people transcribe that information into standardized data or tables. So we call EHR data becomes that category. And this second layer is the bottleneck, because that bottleneck requires intelligence to read. And before AI, the intelligence couldn't really read and classify into codes. And so to standardize the data. And that bottleneck means that most of the information is not real time. It's at least a few weeks, months old. During the pandemic, we discovered this, that we were overwhelmed with the sheer volume data, and we had to train AI to do the reading. And we read it at this middle level, the natural language level. And so that means that if we can get AI to do the reading, or to do a lot of the reading, then we can reduce the burden on the people at the bottom and the people at the top. And so a lot of that data is what we call unstructured. So it's in Word documents, PDF, text files, images of documents, of letters, and a lot of this information is all kind of unstandardized and in all kind of free form, random emails that people write to each other and things like that. Whereas at the top, all the nice clean data, all the data that's coded by clinical coders, and they all tend to try to follow a standardized system. And so all the big thing at the bottom was traditionally not mined, but this is what we call the deep data. That's where actually a lot of the outcomes are captured, a lot of the symptoms, a lot of the comorbidities, all the additional information. And so a lot of what I did in the early 2010s was what we first to do is chuck all the data into one place, all the unstructured data, put it all into lakes on the left, big lakes, and then use automation to sort it. Rather than using the human right at the beginning to pull data out or input it, we use automation at the pooling and the standardization phase, and the dark blue side on the left. And on the right, the light blue side is where we use specialists to do that. So we use clinical coders, analysts, people with knowledge of it to add meaning to it and then to construct things with it. And the bits on the right are much more specialty specific or healthcare specific or specific to the question, and whereas the things on the left are much more AI friendly and much more automation friendly. And we've been doing this, as I say, for a decade now, actually. So a lot of our work was right at the beginning, 2014-15 in the UK during the 100K Genome Project. And during that time, we were asked a question: can you find all the patients with no diagnosis yet? And we will sequence them for the genomes. And no diagnosis is something that you can't find in structured data at ICD-10 codes and such, because they don't have a diagnosis. And so we use search. We use a language AI to search, and we built a lot of our early technology, and we started deploying it in different hospitals. At the same time, at the bottom, the green arrows represents what's happening in the wider internet, where people were training different types of language AI. Since then, we've been building this within the hospitals around London and a few places around the world. And so this language AI, essentially, just for reading, this doesn't do anything. The typing is not by AI, it's by a human. And this is what it does, which is, it's not very, it's like a spell checker, but instead of spell checking, it picks up medical concepts and it matches them to standardized codes. And it detects the grammar. So for example, night sweats, it says no night sweats, meaning that it's a negation. So it detects the grammar around that. It can detect symptoms, it can detect diagnosis, comorbidities, even kind of walks with a Zimmer frame, the function and morbidity and things like that. And it detects obviously spelling errors and things like that. But this very, very simple thing that you see is actually quite hard to do and train. And once it can do that, it can do a lot of things, because it can read for you. And you can obviously teach it as well. If it mistakes breathlessness as something else, then you can mark it right and wrong, and it learns. And so you have someone who can read for you that can then submit data somewhere else. And then if we take that single sentence thing, that reading a single sentence, we take it and we read all the patient's documents. But more than that, we take it to read all the patient's documents for all patients in a hospital for the last 20 years. Everything in the PDFs, the free text and all that. And this is what we did in 2022, where we just read letters. This wasn't even reading registries. This was just reading letters in one hospital. To read 20 years of 1 million patients data took us about a week. So this can definitely scale. And obviously not all of this was 100% accurate. This was just reading just to see whether we could do it. But as you can see, it was already beginning to detect various prevalence and frames of common comorbidities. And how we tend to do it is we tend to build a human in the loop, where the human verifies whether this is true or not, or trains it for a particular disease area. And so, for example, one of the things that we also interested in is whether or not you can support audit. So back in 2021, a stroke audit in the UK involves auditing various strokes units and capturing the episodes. And what typically happens is they hire a research nurse or an analyst to transcribe information from one health record system into the data form, into the national audit. This obviously requires someone who have enough time to read every single episode. And so we trained an AI to just do the reading and to submit and compare whether or not how the reading compares to a human manually single inputting. And we found that unsurprisingly, the human is very accurate, but it tends to miss, because if you have 300 pages of a very long stay inpatient, you're going to miss occasional bits of information, whereas in AI is more likely to pick it up. And so we detect all the lots of comorbidities and outcomes just through this work. And so this is how I see this working. And so it supports existing audit by enriching the data, making and suggesting things to reduce the burden of the manual data entry. And then when other groups heard about this, they said, oh, let's try this for creating research registries. So we did epilepsy medications, all the from reading outpatient letters, how the different medications swap over 10 years. The cardiologists became interested and wanted to create an aortic stenosis registry and all their valve surgery. And so they generated that. And this is all from retrospective data for the last 15, 20 years. Then obviously more and more people started appearing around wanting to generate registries on the tab. And these are essentially big data marts which support both structured data and unstructured data. So even kind of something that's not typically considered a disease like end of life care, how do we, palliative care, to understand the language around that is key. And obviously it is a very sensitive area, so which is why we had to work very closely with patients and relatives with this. And so we can just generate this on the fly now. And these are all not just in my hospitals and a few other hospitals around London and in Manchester and Wessex and Amsterdam, where we install some of the software, which they can all run locally. So we don't have to send data anywhere, or you can run in the cloud if you need to. And so you can see these just keeps generating, and we look through all different types of diseases. And so the last bit is that once we generate all this, what became really interesting to us was, could we do this at a national scale, or to do it not just to record, to describe what is happening, because this is an audit here in this context is all about describing. How about predicting? So if you have enough information of all the codes generated from the registries, you could do predictions. So we get in 2023, we train an AI on those 20 years of data for the 1 million patients, or well, 3 million in that case by that time, in which we arrange the codes like words in a sentence, the diagnosis codes as words in a sentence, and symptom codes as words in a sentence. And then we train an AI to try to auto-complete the sentence, which is basically auto-complete a patient's life or their future. And so we could show that it could forecast across many diseases. So it was a model of not just a stroke prediction model or dementia prediction model or celiac disease prediction model. It makes all predictions at once. So, which is actually what is true, more realistic for a patient. But this was only 3 million patients in London, kind of a subset, and so obviously it could be heavily biased. And so, but we certainly showed that it's possible and that you could do all kinds of predictions. And we then started working, and you may have seen recently that we in NHS London for the whole country, we've been training this foresight on 57 million individuals across all of the UK. And what we again, this is to train ultimate models, which can then do predictions. It may not be predictions of a single patient, but it can be a prediction of the whole population. So you see how many patients are likely to have strokes in the next 20 years, or the next 5 years or something. And so these are general forecasters. But it could also be what we call a patient twin. So you could generate an imaginary person that looks like, that has all the traits as your health as you. And then you could experiment to see which one, if you add this treatment, what's the outcome? If you add that treatment, what's the outcome? Or you could use that as a benchmark to see whether how a particular patient's outcome strays from what the model predicts. And that could form, again, a basis for some sort of performance tracking. So that this is just to show you kind of what we're working on in the future, but what it all boils down to is the data is good enough, and if you make it rich enough, and if you can do this without hiring more and more people to feed the beast, then you will be able to do this at scale. And this, as I say, we keep this human in a loop throughout this process. A lot of the people who train the AI are analysts and clinical coders who work doing this task. The issue is not that there is not going to be enough work for people. There's just too much work for people right now. So I think that a lot of the fears are perhaps a result of the hype cycle over-promising. So that's all from me. I'm happy to take on more questions and such, and I will stop sharing. Thank you.
Thanks, James. That's fantastic. And again, it's just really fascinating where we are. And I'm going to get you to join me now with we're going to invite Kevin back, and we're going to be joined now by Majella as well. And I'm hoping that we're going to get some questions from our audience, and I think we'll keep an eye out for those. But Majella, I might ask you for your thoughts first. Just you've got to hear Kevin and you've got to hear James, and I suppose in relation to specifically clinical audit, what are your thoughts about the potential of AI?
Yeah, well, thank you so much, both of you. And Professor Theo, looks really exciting to see how you're actually applying it in practice now and where you're planning to go in the future. And I suppose I really, what you were saying around the unstructured data piece rings so true for me here in Ireland. There was a recent survey completed by our technology and transformation colleagues, and around 80% of our records here are still on paper. And while we're moving towards EHR and so on, we're not there yet. So just how would we start with using this technology when we're so paper-based here in Ireland for large-scale projects and even small-scale audits within our settings?
So as the hierarchy of needs here, you need to sort out infrastructure bit at the bottom first. Don't run before you walk. I mean, a lot of the language AI technologies can read scanned images. Obviously, the scanned images is depends on the quality of the person's handwriting, which I can confess myself that my handwriting is atrocious and it can't read mine. So I would say that typed documents, scanned documents, it can handle. I would say that if you invest in digital infrastructure, there is more and more sense that it's less important the complexity of the forms. You can build all kinds of very complicated e-forms for people to fill. We all know what human nature is like. If the form looks too complicated, people will fill in either garbage or just type stuff into the text box. So I think my recommendation is to use such technology is to use the opportunity to leapfrog what the mistakes of the past. I regularly encounter in London, for example, lots of old databases which are over-designed. And you don't need to over-design so much anymore. You can actually simplify through text, just free text.
Okay, great, thank you. And Kevin, again, I just have a question. Local services might be thinking about using AI, might have come across something on the internet or whatever that might be an idea. How do we make sure that, staff don't go about implementing AI without proper guidance and so on within the HSE? Is there kind of a pathway to guide them how they might start using AI within their local services?
Yeah, and that's going to be part of the work of the Centre of Excellence now that we're currently, we've established, but it's still a work in progress. But yeah, if anybody has any ideas, that they can approach us, absolutely, and the contact details will be up there at the end. Because a part of our work will be to help support that innovation, but to ensure that we don't have projects out there that just die on the vine, if you like, and that we're assisting people to have rigorous procurements, have the funding in place, so that you find those real nuggets and those exemplars, that we have an opportunity then to scale that work across the country. So if particular offices or regions are looking at something in that vein, and it's successful, we want to be able to scale that quickly. So yeah, just approach us and we'll take it from there.
Great. We'll share your details at the end. Thanks, Kevin. John, back to you. There's some questions coming in, I think, in the chat.
Yeah. I'm just interested there, kind of one, maybe building on your question there, Majella, what are the main ethical considerations for the work that you've presented? And I'm interested in this, again, I suppose, we know what AI, we're learning what AI can do, but do we really know yet what we want it to do? What are the things that we really, want? What's very important to us, I think, and again, who has power over that? James, I might give that to you first.
Okay,
if
all
that's
right,
okay.
thanks. I think a lot of it depends on, as you say, what you're using the AI for. So if you're using the AI for, let's say, things which we already do, but very slowly, let's say forecasting, demand planning, and all that, then there is certainly under the UK legal framework, it's less about the methodology, but whether there is legal basis for that. And there would be legal basis, and obviously you have to go through the various legislative steps. I see a question from Orla as well around the training on the 57 million. This was all done by the national government. We do it within secure data environments held by the UK government, by the NHS. We go in there and we install the AI there. We deploy it. It's all local. It doesn't send data anywhere else in the world. So I think there is a kind of a conflation of AI with what everything big tech or Google or Microsoft on Facebook and all do. A lot of the AI that was built can run on your own laptop, or you can run it in a closed data center held by a secure entity. And so I would say that those are the kind of, so that there's ethical framework, there's legal basis or data protection, as well as what the purpose is. So those three things all interact, but they're often conflated into the same thing.
Great, thanks, James. And there's a question there, maybe Kevin, for you. You know, one of the big concerns about using AI tools relates to data security, particularly relating to sensitive patient information. And how do you ensure the security of this data when interacting with large language models?
Oh, it's a really good question, and it's a very important point. We have to be absolutely sure that the data that we use or we provide to an AI model, in many cases would have to be anonymized, maybe, or, you know, and if we're using patient data to train models, that data is anonymized, that there can be no chance of identification of a living person, and I think that's how the law describes it. But in terms of, and there's a question too, and I think the British government were having some questions around the intellectual property of public data. That's something that's a consideration for us as well, and we need to be really careful that the data that we have remains within our sort of custody, if you like. It's patient data at the end of the day, and that data is the patient. We're custodians of it, and we have a responsibility to absolutely protect that. So again, it's almost adopting that defensive posture, but trying not to be an inhibitor either, where there is value in giving some level of data to help patient care down the road. But hopefully that some way answers the question. But it could be the basis of a talk time on its own, I think.
Yes, absolutely, and I think this is a changing and emerging area as well, and we're all learning.
Yeah, I think just GDPR is mentioned there in the chat as well, and GDPR is mentioned in the guidance that were published by Deeper as well, that, you know, we are using information responsibly and safely and so on. So I guess, Kevin, whatever guidance will come out in terms of advising people around deciding whether they're going to use AI for data analysis and so on, all of that will be in there to so that people are mindful of their information governance requirements and GDPR and so on.
No, absolutely, Majella, and just one point to make on the recent guidelines from government was around the use of Gen AI and free Gen AI tools, and not using public data to train those models. So we're going to have to adopt a position on that. It's up for discussion right now, as I know, and we'll be forming a position on that quite quickly, given the recommendations that we've now received.
James, can I ask you a question? I know you pointed out that we're in the hype phase at the moment, but maybe just allow yourself a little indulgence, and you know, where do you think we're going to be in 5 years' time with this, or you know, and what are the really important things that it's going to help us with?
Oh gosh, fantasize sort of make a prophecy of the future and definitely gonna get it wrong now. So I mean the trending items right now that everyone's talking about in the world is what called agentic AI. So AI not necessarily to answer the question, but AI to carry out tasks which then answer the question. And I think that is potentially very, very interesting. I would say that it's not mature enough in the healthcare space. Maybe in 5 years it will be. But the main reason it's not mature enough is that a lot of the digital systems don't have anything for the AI to talk to. And so you need to get the basic infrastructure ready for that. I would say that my hope in the next 5 years is that people will begin to really love using these AIs locally. So we you know, in the past you had software on your phone or your software on your computer. You didn't send data anywhere. If you wrote a Microsoft Word document on a computer, it stays on your computer. And I would say that the tension between AI using what we call APIs to send data to an AI somewhere in the cloud, then getting the answer back. I think that tension between the advantages of that versus doing it all on device or on the computer that you're seeing the patient with, that I think will be my hope, that people suddenly realize, okay, actually, AI that answers to me and only me is going to be safe, because, and the patient as well.
Yeah.
And so that's my hope, and I hope that will open up the door to patient generated information. So I think right now we are relying too much on doctors to put in information, or healthcare professionals put in information, and patient-generated information will likely be a very exciting new area.
Absolutely. I think in quality improvement, we see that kind of patient-reported outcome and experience measurement has been critical, I think, to really advancing improvement. And Kevin, just for you, I think one of the things just that James kind of keeps coming back to is that the bottom of his pyramid is the infrastructure. And do you think are we getting there fast enough? Do we need to do more? Do we need government to engage with this more?
Government are heavily engaged in this, and I'll say that in case there's any of them listening, but they are really supportive of the work we're doing. But I think one of the fundamental components of this is good data, and that's the appointment of Tom as in his new role as the CDAO is a clear signal that we need to get our data right. Because what AI produces is only going to be as good as the data we get in. So for me, that's one of the major fundamental building blocks as we move forward. But look at CDAO is in position now; it's in place, and to accompany or in parallel to the drafting of an AI strategy, you're also going to see a data strategy also emerge in the same time frame as the AI strategy. So we'll see where that brings us.
That's fantastic. So we all have a role really to play in this. Well, I'm going to thank James and Kevin. Thank you very much for your contribution. It's been fascinating, and I think our audience is lit up there. I'm going to hand over to Majella, who's just going to make us aware of some of the resources that are out there now, and to highlight the Clinical Audit Awareness Week that's coming up.
Thank you, John, and thanks, Chris. And just while those slides are coming up, just to say we have spoken to Tom and Kevin around the AI strategy, and we're hoping that clinical audit will be included within the strategic pillars there as well with the DOH. So more on that, we hope. So just very briefly to signpost you to what's happening next week, Clinical Audit Awareness Week. So look, there's a number of events scheduled. I just want to highlight what's happening from an NCCA perspective, but more importantly to hear from you in terms of what you're planning to do to promote clinical audit and quality improvement within your local service areas using local audit data and indeed your national audit data reports as well. Also want to signpost the re-establishment of the Irish Clinical Audit Network and some resources on our website. So we're starting on the bank holiday with social media announcements, and they'll be going on throughout the week, and we'll be linking in with HQIP in the UK and other colleagues such as NOCA and so on throughout the week, sharing our social media announcements, again, all collectively trying to promote clinical audit throughout our services. We have two of our clinical audit facilitators, Mags and Alison, promoting the work of Clinical Audit Awareness Week and the work of NCCA, and that video will launch on Tuesday. And then on Wednesday, we have a drop-in clinic where we will have an hour-long session with you, listening to you and answering questions around clinical audit, implementing best practice in clinical audit, very much based on our practical guide 2023, which is going to be updated and relaunched for 2025 imminently. So really interactive sessions. So particularly for staff that don't have access to QPS or clinical audit personnel in your local services, definitely a good one to join onto. And then we're very pleased on Thursday, Orla, will be opening our lightning talks, which is around a number of national audits that are being led by clinicians who you can see listed there. So a national sepsis lead, our national falls audit lead, and our national in-hospital cardiac arrest audit lead. And they'll be sharing their experience from a governance perspective, standards, data management, etc., but in the context of how AI and human factors apply, as is the theme of our week, for their national audit. So a good opportunity again to learn and share information. And then finally on Friday, we're very pleased that we've had a number of presentations and case studies submitted to the NCCA for Clinical Audit Awareness Week, and we're going to have 4 speakers presenting orally on those, but we'll also be sharing the information that came in from the other case studies. So our 4 topics are around cardiac rehabilitation, escalation and response to INU scores, delirium identification and management in ED departments, and enhancing compliance with WHO surgical safety checklists. So again, we were aiming for a blend of hospital and community services audit audits from a point of view of sharing. Again, out and about events, we want to hear from you. Whatever you're doing for Clinical Audit Awareness Week, last week, this week, the following week, let us know. We're trying to participate in them as much as possible. Send in your photographs and your updates, and we'll hopefully prepare a storyboard then that we can share across the country afterwards. We'd also like to signpost you to the Clinical Audit Network, and that was re-established earlier this year with Dr. Robert Conney and colleagues. Our next meeting is on the 11th of June. If you'd like to find out more information about the network, again, it's a learning and sharing forum. Contact the NCCA and we'll share details with you, and we'd be delighted to have new members. And our clinical audit portal, which has just gone live in the last few weeks. Again, this is aiming to be a one-stop shop to share national clinical audit reports and for you to share local clinical audit reports with us, audit tools, etc. And from an NCCA perspective, that it's a one-stop shop to all of the resources, practical guides, clinical audit tools, etc. That's available through the link that's on the slides there, and also available through our NCCA webpage. So this is an area that we'll be growing with you. So very much looking forward to working with you in development and sharing information and resources there. And our next slide, I think, just takes us to our existing resources, clinical audit training schedules and so on. So please link in with us through LinkedIn over the next few days and through our email. So thank you, John.
Thanks, Majella, and lots of things happening there. So people may not get to everything, but hopefully they'll get to something. And those will be up on the website as well, and lots of links there in the chat too. So fantastic. This has been a fantastic, fascinating session, and I have a feeling we'll be coming back to this topic soon. I think both clinical audit and AI certainly, I think, are things that are of great interest to our audience. I'm just going to, yes, so just the next QPS talk time there is in 2 weeks' time, 10th of June. So again, watch out for some further information on that. You can scan that there to register. And that's on using QI methodologies to improve services. So we'll be letting you know more about that soon, but put it in the diary now. You can watch back on previous episodes of QPS Talk Time on YouTube or Spotify. And again, the QR codes there will take you to those. And let us know how we did today. You will get an email asking just for your feedback. Please give it to us. Or if you can't wait that long, you can scan the QR code there now and you can give us your feedback directly through that. And thank you all for joining us today. And thank you especially again to James and Kevin and Majella and Orla. Thanks to Chris and to Juanita, who do all the hard work in the background. And we look forward to seeing you in a couple of weeks' time. All the best.